thyroid nodules. Background: ultrasonography of the thyroid and ultrasonographically guided fine needle aspiration can help determine whether a nodule is probably benign or malignant. In the absence of growth or suspicious clinical or radiological findings, nodules with a benign finding on FNA can be monitored.
Thyroid nodules are areas of excess growth within the thyroid gland, and they're pretty common. Up to 30% of the population will have at least one thyroid nodule, and women especially, by the age of 50% of women will have at least one thyroid nodule. So very common. Thyroid nodules can have cancer. Oftentimes they don't. Most of the time, thyroid nodules are benign. In general, any nodule greater than 1 centimeter in size should be biopsied to determine a malignancy risk. In order to do that, you need to have a fine needle aspiration biopsy, which pulls cells from the nodule itself. The needle used for the biopsy is smaller than the needles that we use to draw blood. Patients generally describe it as a small poke or pinch through the skin, and then you can feel pressure as the needle is actually passaged through the thyroid nodule. Generally, it's very well tolerated. Oftentimes in the community, when you're determined to require a thyroid nodule biopsy, you're referred to a biopsy center. Most of the time they are radiology centers. And oftentimes they do not have an on-site cytopathologist who can examine the cells, and then the cells are sent to a laboratory somewhere where the cytopathologists evaluate those cells. Sometimes at the initial point of the biopsy, not enough cells were collected, and so you end up with a quote-unquote non-diagnostic biopsy result because there just weren't enough thyroid cells in the sample. And those patients will often have to go for a second biopsy, but because of the inflammation from the first biopsy, they have to wait up to 2 to 3 months to have that repeat biopsy, which can prolong the evaluation process. Here at Columbia, with our thyroid biopsy clinic, we have on-site cell pathologists. They're in the room to immediately assess the cells and make sure that we have enough cells to make a diagnosis. So oftentimes we are able to avoid the non-diagnostic biopsy result, which is much more expedient and kind of facilitates getting the patients the care that they want. How is that? Good?
Not bad at all.
Good. Applications in medicine. Radioactive iodine 131 ablation is the first-line treatment for hyperfunctioning thyroid nodules. Because activity in the surrounding tissues is suppressed, there is little uptake of the isotope in the tissue outside the nodules, and there does not seem to be any significant damage to the remainder of the thyroid. Although thyroid cancer is more common after radioiodine treatment, this cancer tends to be less aggressive. Therefore, the overall thyroid cancer mortality rate is not increased.
A biopsy is the best way to find out if a thyroid nodule is cancerous or not. Most patients describe the procedure as tolerable and have minimal discomfort. We have performed thousands of biopsies in our office with no major complications. This safe and routine procedure will use ultrasound to guide the biopsy. Here's what you can expect during the procedure. The chair will recline to put your head back into position. The doctor will use an ultrasound probe to find the thyroid nodule and measure its blood flow and stiffness. Then you will extend your neck and tilt your head. After cleaning the skin over the nodule, the doctor will numb your skin with medicine given through a tiny needle. About a minute later, the doctor will use the same size needle to collect a tissue sample from your nodule. The doctor can see the needle on the ultrasound screen at all times. Each biopsy sample takes only 3 to 5 seconds to collect. Please do not swallow during the procedure. This process is repeated once or twice for each nodule to get tissue from different areas of the nodule. During each sample, try to stay calm and breathe easy. After the procedure, we will check your blood pressure, and you will press gently on your neck for about 5 minutes. You can do all your normal activities the day after the biopsy. A pathologist will review the samples, and a nurse will call you with your biopsy results, usually within 1 week of your procedure.
Pros. Once the nodule is discovered, your doctor will try to determine whether the rest of your thyroid is healthy or whether the thyroid gland has been affected by a more general condition such as hyperthyroidism or hypothyroidism.
The vast majority of thyroid nodules are benign, but a small percentage are malignant. Some of them affect the function of the thyroid, and some of them do not affect the function until late in the course of the treatment. When a patient presents with a thyroid nodule, the most important thing is to get to know that patient and find out in the general health status. And then the evaluation of the thyroid nodule it's important to have sophisticated imaging, specifically with an ultrasound, to determine the nature of the nodule. Solid nodules generally are related to tumor formation, both benign and malignant, whereas cystic nodules are generally benign conditions that can be treated conservatively. In most patients, the next step is to do a fine needle aspirate, a sampling of cells that are evaluated by a pathologist. And the skill of the pathologist is critical because they're looking at a handful of cells to try to make a diagnosis and separate benign from malignant. Every patient has options for treatment. Many benign nodules that are small and either growing slowly or not growing at all can be managed conservatively with periodic exams and blood tests. Patients with nodules that are expanding, either benign or malignant, surgery is the best treatment for that, because surgery for thyroid, both benign and malignant conditions, is potentially curable. The operation, though, is delicate and requires a certain amount of expertise because of the presence of the thyroid is located in the central portion of the neck with adjacent blood vessels and nerves, as well as adjacent glands that regulate the level of calcium in the bloodstream. And alteration of calcium metabolism can lead to serious nerve and muscle problems. Injury to the nerves that control the voice box can lead to hoarseness chronically or transiently or permanently. And so surgical management requires a lot of expertise and experience.
Cons. Occasionally, nodules may cause pain, and even rare still are those patients who complain of difficulty swallowing when a nodule is large enough and positioned in such a way that it impedes the normal passage of food through the esophagus, which lies behind the trachea and thyroid. Thyroid nodules found this way, by accident, are cancerous for less than 1% of the time.
Thyroid nodules. The most common cause of having thyroid nodules is a thyroid problem, hypofunction usually. Of course, if you have thyroid nodules, you need to go to a doctor that specializes in that, because we want to make sure that there's nothing else going on. We want to rule out cancer or anything else that's going on. But I've had patients that have thyroid nodules and they have part of their thyroid removed. When they did the pathology report, it was negative. So it wasn't cancer, it wasn't anything else, it's just nodules, and they removed them because they do swell, they can affect your swallowing ability, you feel some pressure right there, and they do swell, and it affects, the way that people can look at, wow, it's kind of swollen right in that area. But if you're taking thyroid medicine and you still have nodules, or you're taking thyroid medicine, they removed the nodules, but you still have all the symptoms, they didn't figure out what's causing the problem. So if you have thyroid nodules, they've done an ultrasound, they've done the diagnostic testing, and they can't find anything wrong with it, or if they remove the nodules, they're still having symptoms, it's a good chance that you could be a candidate for our program. We have to figure it out. We have to evaluate you, consultation, examination, see if you are a candidate. But if you tried those other methods and you're still having thyroid symptoms, chances are our program can help you. Just want to give you a little bit of information on how we look at things differently, and we think outside the box on these type of problems. So if you've done the other methods and it's not helping you, you're still having your hair fall out, you can't lose weight, or you lose weight and it comes back, you don't have any energy, your hands and feet are cold, your nose is cold, your body's warm, you're having irritable bowel, any type of intestinal problems, reflux, dizziness, all of those symptoms. If you take the medicine, those, and you're that pattern, those should be gone. So if they're not, let's see if you're a candidate for our program.
Conclusion. We don't know what causes most thyroid nodules, but they are extremely common. By age 60, about 1/2 of all people have thyroid nodules that can be found either through examination or with imaging. Fortunately, over 90% of such nodules are benign. Hashimoto's thyroiditis, which is the most common cause of hypothyroidism, is associated with an increased risk of thyroid nodules. Iodine deficient, which is very uncommon in the United States, is also known to cause thyroid nodules.
I had a nagging cough that happened anytime I spoke, anytime I sang in church. Public speaking was a nightmare to me because I would begin to cough almost constantly. My primary care physician had determined that I had a thyroid nodule.
The thyroid gland is a gland we all have in our neck, and it helps in the metabolism of the bodily functions. So everybody has a thyroid, but everyone doesn't really understand what it does.
So I saw Dr. Pollard. He sat down. He took a lot of time with me to explain what my options were, and gave me the choice to either have a procedure at that time or to monitor for a while. And I selected to monitor throughout the summer, and the nodule began to grow. So I came back and saw Dr. Pollard. At that time, he didn't give me a choice. He gave me his decision, which was we needed to get this nodule out.
Thyroid is a gland that's right around or just below our Adam's apple. So it's located to the right and to the left and just over our windpipe. So a surgery to treat that requires an incision where you can go in and remove the important part of the thyroid that's suspicious for cancer, but there's a lot of very important structures in our neck, and so the surgery has to be designed to take that out and not injure any of the nearby structures.
I was worried it was cancerous, but along with it, it became the explanation for why I had this cough for so long. And when you carry with you a cough for years, and you've struggled to find out why and had many, many tests over the years, finding resolution to that and finding out that you don't have cancer, that's two great blessings. Of course, I'm grateful that the nodule was benign, but now that it's gone, I was driving down the freeway one day, maybe about 2 weeks after the surgery, and I found myself singing to the radio in the car, and I just began to cry because I thought, I'm singing and I'm not coughing.
Thank you.